Good afternoon. This is the November Pharmacology talk on salbutamol. Salbutamol is a drug used in all UK ambulance trusts and is a really common drug which is often used for the treatment of a wide range of respiratory illnesses. Pharmacology terms, it's what we call a selective beta-2 agonist. And breaking that down, if we think about how nerve impulses transmit messages to cause actions around the body, we have these gaps between the nerves called synapses, where chemicals known as neurotransmitters are pushed across the gap to either turn off or turn on certain switches, which would elicit some kind of action in the body. Now, in the terms of respiratory constriction and dilation, this is mediated by two main switches, which are the muscarinic free switches, which cause the bronchoconstriction, and the beta-2 switches, which would cause bronchodilation. Salbutamol turns these beta-2 switches on, hence it's an agonist, which would then create this bronchodilation, relaxing that smooth muscle and making the airways bigger. The reason why it's called a selective beta-2 agonist is that there is a whole load of different switches in the adrenergic receptors. These could be either alpha-1, alpha-2, beta-1 through beta-3, and salbutamol only turns on the beta-2 receptor. If we were to talk about a non-selective drug, such as ipratropium bromide, that would switch on several of the muscarinic, or switch off several of the muscarinic switches, working in the opposite effect of switching off bronchoconstriction to ease in, making those airways bigger and relieving the respiratory distress. So there's several different kinds of these beta-2 agonists, which can be broken down into how long they have an effect for. We've got these short-acting beta agonists, which last between 3 and 6 hours. We've got long-acting beta agonists, which can last for about 12 hours. And in recent years, we're starting to release ultra-long-acting beta agonists, which would have an effect for about 24 hours. Salbutamol comes under this short-acting category. So this is really important to be thinking about when we're treating and potentially discharging patients. This will only be of effect for about 3 to 6 hours. In terms of presentation, it can come in a multitude of different forms. We've got the trusty blue inhaler that we're all aware of, which one puff would be equal to about 100 micrograms of salbutamol. We can get these nebules for aerosolizing, which can come in either 2.5 or 5 milligram nebules, and they'd be equivalent to 25 to 50 puffs of an inhaler. Or when we're thinking more critical care and in hospital treatment, we can get IV salbutamol. Now, in some trusts will stock 2.5 milligrams, other trusts will stock 5 milligrams. In my trust in Scotland, we tend to stock the 2.5s, but occasionally we will have supply shortages and have to get in the 5 milligrams. It's really important, therefore, to do the drug checks to make sure that we're giving the right nebula and not under or overdosing our patient. It's an interesting note to make as well about the storage of salbutamol. It is reactive to light, and if it's left out in sunlight, it will degrade the drug. So it's important that these are kept in foil wrappers in our medication bags, and also they shouldn't be stored above 25 degrees. Now, back when I was trained, the start of the 2010s, there was a note in the JL Calc saying that we weren't to be mixing salbutamol with ipratropium bromide. There was no reasoning given in JL Calc as to why this should be the case. However, a few reasons that were suggested seemed to be that we were potentially creating this new drug, maybe worsening side effects, or the acorns that we're nebulizing in were struggling to aerosolize that volume. We never did get an answer as to why this is the case, but that has now been removed from JL Calc and does seem to be a common practice in multiple trusts to mix the two together. Personally, for me, I still like to give them separately, so to give salbutamol to reassess the patient to see if further ipratropium dose is needed. However, if I had a particularly unwell patient, or if I was working with somebody who wanted to mix them, I wouldn't see any harm in them doing this. So under our indications and JR Calc for when we'd give salbutamol, The first one would be for an acute asthma where normal inhaler therapy has failed to relieve symptoms. We've got an expiratory wheeze associated with numerous medical causes, and we've got an exacerbation of COPD. It's worth noting that the exacerbation of COPD, it doesn't require a wheeze. A lot of the time we will associate the presence of a wheeze with needing salbutamol, but COPD patients won't always present with a wheeze, and that doesn't mean they should be excluded from receiving this drug. So we'll have a look at some of these circumstances and when we'll give salbutamol and the nuances behind what we should be thinking about when administering it. So the first circumstance would be in asthma. And we can really overcomplicate the pathophysiology of asthma, but in basic, we've got a patient who's relatively normal functioning lungs, and then due to some kind of irritation, whether it be an allergen or irritant, they have this over response, which causes bronchoconstriction, which causes a wheeze. Our salbutamol will correct this over response and hopefully get them back to normal functioning. They may need steroids or further doses of salbutamol to get them to this stable state, but in effect, we are just correcting this over response to the body. Now, our treatment for asthma will very much depend on the severity of how bad this over response is. JR Calc breaks it down into mild, moderate, severe, and life-threatening. We have mild asthma, which means that the patient is just suffering from slight reduced in activity. We have moderate asthma, which is considered just a bit worse than mild, but are still able to speak full sentences. We have severe cases where they can't complete full sentences, and we start to see the OBS starting to go a bit deranged. We're getting a tachycardia, we're getting an increase in respirate. And then we've got life-threatening, where the patient's starting to suffer the effects of hypoxia, they're starting to get reduced GCS, the SATs are going down below 92%, there's no longer any air entry in their lungs, remembering that the problem with asthma isn't that you can't get the air into the lungs, it's that you can't get the air out of the lungs. So our treatment for mild asthma is obviously we first want to remove the cause, and we want to really encourage their own inhaler use. This recommendation would be to take 2 puffs of their own inhaler every 2 minutes up to a maximum of 10 puffs. If they're not receiving any relief after 10 puffs, then we need to be thinking, is this asthma, or do we need to be treating with something a bit more aggressively? If they're in this moderate category, being a bit worse than mild, then we would be looking at administering nebulized salbutamol. It's really when they hit this severe category that we start to look at tailoring treatment more, where we'd be giving salbutamol followed by ipratropium bromide, followed by repeated salbutamol doses, then administering steroids. And then when we get to life-threatening, that's when we're looking at critical care interventions. So if you have a critical care team available, magnesium, we'd all, as paramedics and technicians, would be able to give adrenaline, IM, and consider decompression. Now, this wouldn't be needle decompression like you would for a tension pneumothorax. However, tension pneumothorax is often associated with asthma. So that is worth keeping in the back of your mind of, has this patient blown a pneumothorax and is that tensioning? But more of manual decompression. So that is somehow putting pressure on the chest to force that air out. I've seen this done in 2 different ways. It's either a patient who's able to sit or stand up to wrap your arms around them and compress the chest down. And I've also seen it where a patient is unconscious, where you've done effectively chest compressions, but around different areas of the chest to really push the air out. GL Coke does now note that although salbutamol will provide initial relief, as we said previously, it is short-acting, and further treatment may be required to stabilise this patient, be that further nebs or the use of steroids. It's really important not to be lulled into false sense of security just because the patient initially improved. The last thing we want to do is to leave these patients at home, be called back a few hours later because they've exacerbated again. So we need to really make sure these patients are getting all the treatment they need. And when we talk about COPD, if you remember me saying about the asthma, you started with someone who's relatively normal in function, and then with the salbutamol was getting them back to their over normal function. In COPD, you got somebody with chronic reduced function, and then due to either an infection or an irritant, their function gets worse. Now, salbutamol will only temporarily improve that function while we try and treat the underlying infection or irritant. So this can be demonstrated in the NICE guidelines for whether a patient requires hospital admission or they're suitable for home discharge. Now, the hospital admission, it's all pretty obvious stuff, things that we wouldn't really consider leaving at home. But it's interesting to look at for the home discharge package they recommend. COPD exacerbations should be prescribed with steroids, antibiotics, and again, a review for alternative diagnosis. Things that we as paramedics are not going to be able to provide them. So what this really means is that for any COPD exacerbation, they should receive a referral if they're being left at home, and be that either to a GP or their specialist team. Now in Scotland, where I work, we've got this COPD pathway, which is a national pathway, where these patients can be referred to local COPD specialists. This is the flow chart that you'd follow. It's available on JR Calc. In short, if the patient is time critical, we obviously want to transfer to A&E. If we're unable to control the symptoms at home, we'd still be transferring them to A&E. If, however, we can control these symptoms, and the same as asthma patients, we want them to be stable for a minimum of 30 minutes to make sure they're not going to re-exacerbate, then we can consider referring them onto an approved pathway with safety netting advice. Also important to note on this flowchart, if the call has come from a GP or another healthcare professional, both as common courtesy to that professional and as good practice, we should be contacting them to update and discuss. I've got several friends who work in primary care. There's nothing more frustrating than them reviewing a patient, arranging for ambulance transfer to hospital, coming in the next day, looking up to see how their patient's gone and find out they never actually attended and not knowing why. It's not to say that that the GP was wrong to contact the ambulance, but it's just about keeping them in the loop and having that discussion to say that you think actually there is a better pathway that this patient can go along to receive help rather than A&E. So before making this referral, all the numbers will be available on the JR Calc Plus app under the Pathways tab. And along with that, there'll be this assessment checklist just to go through. These are the kind of questions that they'll be asking when making the referral, just to ensure that when someone comes out and reassess them, that actually this patient didn't need some kind of specialist care and they're going to end up with another call to the ambulance service to transfer them through to hospital. Now, this is the line that always comes up when we're talking about nebulizing COPD patients, that we should be limiting nebulization to 6 minutes. And this can often be a sticking point for a lot of clinicians and can be the focus of when we're treating that. We really, really have to be careful not to over-oxygenate our patients and not give them nebs for too long. It's worth just looking into where this recommendation has come from and what the evidence is behind it. So first of all, there's a few theories as to why a lot of oxygen may be bad for COPD patients. First one is this idea of a hypoxic drive effect. So in normal functioning patients, if they were to hold their breath, their carbon dioxide levels would rise, which would be picked up by these chemoreceptors, which tell the brain, we need to breathe. In COPD patients, carbon dioxide is always raised. So this effect gets blunted, and the chemoreceptors instead start to pick up on low oxygen levels. So when a COPD patient's oxygen goes low, that's what tells the brain, okay, we need to breathe. We come along, give these COPD patients oxygen, it's taken away that stimulation to breathe. So then they stop breathing. I've seen this a number of times in my career. Fortunately, they self-correct very quickly. All we had to do is take the oxygen off them, and they came back round. Which is a side point, it's very important. If you're giving a COPD patient oxygen and they start to lose consciousness, we don't want to be getting on the floor and start bagging them. We actually just want to remove the oxygen and see if they can self-correct. It normally happens very quickly. This idea as to what causes long-term mortality, the idea of what is causing long-term mortality from overoxygenation has kind of gone out of favour. And is actually thought to be more related to build-up of CO2 because of oxygen. This can be done in one of two ways. And the first one is for the Haldane effect. Now, if we imagine this red blob here is a hemoglobin and this weird eye-looking thing is a cell. Normally, oxygen will jump off a hemoglobin cell and go into the cell, and CO2 will come out of the cell and attach onto the hemoglobin. If we saturate the hemoglobin with oxygen, some will remain on that hemoglobin because it's not required to move into the cell. Therefore, it's harder for the CO2 to latch onto the hemoglobin, so then it will just sit in the bloodstream. It won't attach onto the hemoglobin and go back through to the lungs and be expelled through breathing. This does only normally account for about 20% of CO2 elimination from the body, but it still causes an increase of CO2 in the blood. CO2 is followed by hydrogen, which creates an acid. The blood will become more acidic, cells begin to denature, and that's an overall bad thing for sustaining life. Now, healthy individuals, their first defense for increased CO2 in the blood is to increase their rest rate, to try and breathe off more and more CO2. COPDs can't do this, they're already struggling to breathe, so to put more stress on that isn't going to work. So the CO2 will lead to an acidosis and eventually lead to death. The second way we think CO2 may be building up due to overoxygenation of COPD patients is this idea of VQ mismatch. V standing for ventilation, Q standing for perfusion. Now, the body's really good at optimizing efficiency. In the lungs, we think of these, the blue circles as alveoli, where gas exchange happens, and the boxes underneath as the blood supply to those alveoli. The body will want to send as much blood as possible to the healthy alveoli where there's going to be as much oxygen exchange as possible. And we don't want to be wasting time sending blood to areas where there's going to be no oxygen exchange, such as this damaged alveoli. So in this theoretic example, we're sending 100% of the blood to the healthy alveoli and 0% of the blood to the damaged alveoli. When we give high volumes of oxygen, this takes away this compensatory effect, and we start sending blood to areas where there's not going to be gas exchange. So if you look now, 50% of the blood is being sent to healthy alveoli where there is still gas exchange, but 50% of blood is being sent to damaged alveoli where there is no gas exchange, meaning that CO2 can't escape from the lungs and again just sits in the blood. As we said before, CO2 will lead to acidosis, which will lead to death. So where is the evidence to actually say that the CO2 will equal acidosis, which will equal death? Well, in 2020, the Cochrane Library performed a systematic review looking at whether pre-hospital oxygen in COPD patients will increase mortality. They found only one study for inclusion, and that was this study. In this study, we had two groups of patients of COPD exacerbations. One of them was treated with targeted oxygen saturations between 88 to 92 with air-driven nebs. The second group was given continuous 8 to 10 litres of oxygen with oxygen-driven nebs. The result was we saw a markedly increase in mortality in the high-flow oxygen group with a number needed to harm of about 14. So this would mean if you were to go to 100 COPD patients in your career, you treat them all with high-flow oxygen, you would be harming about 1 in 14. The issue with this study, however, was that the average treatment time for these patients was about 45 minutes. So on average, these patients were treated with high-flow oxygen for 45 minutes. This isn't reflective of the normal of us trying to nebulize a patient for 6+ minutes. There are also relatively small sample sizes. This was a single center study, and the Cochrane report did grade this as low certainty evidence. Now, that's not to say, though, that this CO2 isn't building up because of oxygen. In this study, they were able to, for in-hospital patients, they were able to look at real-time CO2 increases as we nebbed patients. So again, we split the patients into two groups, one being given oxygen-driven nebs, just like we would on the ambulances, and another group being given air-driven nebs. Now, these nebs were given over 15 minutes, with a 5-minute gap in between and then a second neb. If there was a 4 millimeter increase in CO2, that was considered a physiological significant raise of CO2. And if there was an 8 milligram raise in CO2, millimeter raise of CO2, this would be a clinical significance. And above that, there was another safety threshold to say this is a dangerous level. Now, here were the results. Now, obviously, the air-driven nebs, they saw no increase of CO2, so we can rule out that it's the salbutamol causing this. But we did see that there was an increase over that 50 minutes of CO2 in the oxygen-driven neb group. Then after it was removed, these CO2 levels did come down quite rapidly and then went up again and then came down, and all patients stabilised by themselves without intervention. They found 40% of patients did reach this physiological significant level of CO2, and only 2 patients, so 4%, reached this clinically significant. There was 1 patient who had to be removed because they had met the safety criteria during the second neb. They said they were able to self-correct their CO2 levels and required no intervention. So where's 6 minutes come from then? Well, this came from the British Thoracic Society guidelines, who really write all our guidelines on respiratory illness, and our JL Calc will take advice from. And in their guidelines, they stated that it should be limited to 6 minutes, as this is the time they expect us to be able to neb a patient in. So this wasn't anything to do with patient outcomes or CO2 levels or anything physiological. This is the time that we expect you to be able to do this task in, so this is what we're recommending you do it in. Now, this evidence was rated as D level, which is inconsistent or inconclusive study of any level, and really has no backing other than this is a practical recommendation. So what we have here for the limiting oxygen for 6 minutes is we have an uncertain theory supported by weak evidence with relatively arbitrary recommendations, which is very reminding me a lot of our immobilization guidance when it came to C-collars. There wasn't a great deal of evidence behind, and it really became the focus of a lot of our trauma care. But similar to as these C-collars are now coming out of fashion, we shouldn't just be ignoring all the recommendations. We shouldn't just now be saying that we should be treating COPD patients with unlimited amount of oxygen. We shouldn't be just nebbing them indefinitely. There is evidence to say that oxygen-driven nebs for a prolonged time may be causing a patient's damage. What I'm saying through this is, whereas we should try and stick to this guide as much as possible, if for whatever reason it has taken us a bit longer than 6 minutes to give that neb, it is probably okay to expand that time to ensure the patient gets the right amount of medication. So moving on to anaphylaxis. Anaphylaxis can be an absolute pig to try and define. There's loads of different conditions and symptoms going on from all different body systems. But the main issues that we're concerned with is we've got this distributive shock, where the fluid is leaking out of the vessels, causing a low blood pressure. We've got angioedema from that fluid and swelling, causing airway obstruction and stridor. And we've got bronchospasm, where that smooth muscle in the lung is clamping down, causing a wheeze. Now, the reason I wanted to include this is that in a number of simulations, we've found that some paramedics are going in and their first line of treatment for anaphylaxis is to give salbutamol. And that they're correctly identifying anaphylaxis, they're identifying the wheeze, and almost taking a ladder approach of we'll see if salbutamol fixes this before we go on to more aggressive treatments such as adrenaline. The issue we got here is, as we said before, salbutamol is a selective drug. It only turns on these beta-2 receptors. So although that will help with the wheeze, we're not considering the other issues that are going on, such as the increased vascular permeability, so the blood leaking out of the system, which would be mediated by the alpha-1 receptors, and also the issues around blood pressure, which would be mediated by the beta-1 receptors. So ideally, we want all of these switches turned on to try and combat this massive effect that the anaphylaxis is happening. And on the left here, we have the Rhesus Council and JR Calc algorithm for treating anaphylaxis, which should be aggressive treatment with IM adrenaline, followed by high flow O2, followed by more IM adrenaline, followed by IV fluids to try and get this blood pressure up, and only then after all this, we should be considered giving salbutamol ipratropium. Realistically, if I'm attending an anaphylaxis patient, salbutamol isn't on my radar. I'm not thinking about that till much, much later. Really important when it comes to anaphylaxis patients, we want to be getting them there early, giving the adrenaline, treating aggressively. Now, in terms of cardiac arrest, mostly relating to asthmatic cardiac arrest, there used to be this idea that we'd give an inline neb. And for those of you who aren't aware, an inline neb, we have a BVM with 15 litres of oxygen going through it. We have a neb acorn with our salbutamol with 6 to 8 litres going through it. They're joined by a T-piece, and this system is all moving into an ET tube where the air from the salbutamol and the oxygen is forced down into the lungs. So if a patient is not making respiratory efforts because they're in cardiac arrest, we believe this is because of asthma, we can force salbutamol into the lungs to try and relieve this bronchoconstriction. Now, as I mentioned before, the problem with asthmatics is it's not that they can't get enough air in, it's that they can't get air out. So their lungs are already filled with air, there's a massive air pressure, and we're coming along and forcing more air in. But back in 2016, JR Calc released this statement, which originated from some critical care paramedics in London, which suggested that inline nebs aren't actually delivering salbutamol directly to the lungs because of this massive pressure already in there. By adding more pressure, we are further increasing the risk of tension pneumothorax in these patients. And because asthmatic cardiac arrest is not something that we're commonly going to, we've got this complicated and unfamiliar circuit, which people are getting task focused on. I've been to a number of asthmatic cardiac arrests back when this was in practice, and it very much was everyone's focused. We need to get an inline neb set up. We're not practiced at that, and that distracted from good CPR, early defibrillation, and the normal ALS treatment. So off the back of this, JR Calc really concluded that the risks of harm from inline nebs should be considered greater than the likelihood of benefit, and this practice should be completely discontinued. So no trust should be practicing this. This was back in 2016. It was only last year in 2024 that I believe my service in Scotland finally said, no, we're removing T-pieces and inline nebs should no longer be practiced. As far as I'm aware, no trust in the UK is now advocating for this, and this shouldn't be something that anyone is attempting to do. Now, the last consideration is for paediatric patients. There's always been a bit of rumours around how effective nebulisation is for peds, and this mostly comes from the cause of what the wheeze may be from. Now, if we look at this chart, where we got on this multicoloured bar, the age of the patient being preterm on the left to adult on the right. At the top, asthma only tends to really develop when these patients get to around 2 years old. However, their lungs are capable of developing a wheeze from about the age of 2 months. So this first 2-year period of life, what's causing this wheeze if not asthma? Well, if we look at the bar below, kids, as we all know, are really commonly going to get these respiratory viruses. And this is often what's causing that wheeze. Now, if we look at this image, this condition would be called bronchiolitis, and is characterized by inflammation of the airway with a lot of mucus forming. This is separate asthma, whereas although we do get inflammation and mucus forming in asthma, we have the smooth muscle around the airways constricting down. We don't have that in the case of bronchiolitis. And it's that smooth muscle constriction that the salbutamol was trying to treat. So the Cochrane Library in 2014 did a systematic review to look at the effectiveness of bronchodilators on bronchiolitis in kids. And their findings were that bronchodilators such as salbutamol did not improve oxygen saturation, did not reduce hospital admission, did not shorten duration of hospitalization, and did not reduce resolution of illness time. And J.R. Kalk similarly followed this with a statement saying salbutamol is not indicated for bronchiolitis. It will not benefit it, and actually the resultant tachycardia may confuse subsequent clinical assessment in hospital. That being said, I understand that when we go out to these children, they've got really high temperatures, they're strong to breathe, the parents are very anxious, and it is very hard to hear a child wheezing and to not want to do something. We don't want to be accused of not treating a patient. We don't want to be seen to be not doing anything. We'd like to feel in control and that we can actually treat what we're seeing in front of us. So it is worth just thinking next time that you have one of these kids in front of you of just thinking, am I giving this drug because I believe it's going to work? Or am I doing this because I want to feel like I've still got control over the situation? Now, when we're talking about harms of salbutamol, as far as contraindications go, there are none in an emergency situation. If we consider this a genuine emergency due to respiratory distress, we should be giving this to all patients. However, I'm a big advocate of that no drug is without harm, and we shouldn't just be giving it out for any reason. So the harms associated with salbutamol have a number of neurological side effects, including tremor, cramps, nervousness, all the way up to seizures if given very high doses. Cardiac-wise, it can bring on angina attacks, hyper or hypotension, tachycardia. I've always had the number of 140 heart rate in my head of if the heart rate goes above that because of salbutamol, you should discontinue its use. And arrhythmias, interestingly, when looking at asthmatic cardiac arrest, a number of them actually weren't due to hypoxia, but were due to beta-2 agonist-induced arrhythmias. So they had a cardiac cause of arrest rather than asthmatic. A number of metabolic conditions, including hypoglycemia, hypokalemia, acidosis, can give you a sore throat and a dry mouth. Paradoxal bronchospasm. So this is the idea that we can treat somebody with a bronchodilator and it actually cause further constriction of the airway. It's a very rare condition. It would be an absolute nightmare to try and figure out, is this patient's condition just getting worse or is this the medication making it worse? It's not something I've ever seen. It's not particularly something I'd want to ever see. Birth defects, it's really important for me to stress here. This is incredibly weak evidence associated with birth defects. This is not something that we should be withholding a salbutamol from a pregnant lady for if she is in genuine respiratory distress. However, if we don't believe that actually this is required, then we should not be giving salbutamol to somebody, especially if they're pregnant, just to tick a box or because the patient is demanding it. And probably the most common issue that we're going to have is desensitization of beta-2 adrenergic receptors. Remember back to asthma, the first thing that we should be doing is encouraging patients to use their own inhalers to keep them on a low dose of salbutamol. We shouldn't just be going in and straight away nebbing people with the highest dose just because they've called an ambulance, because the more we do it, the less effect it's going to have next time. And I was talking to a paramedic student on the talk the other day who actually said that the guidance for asthma patients has now gone away from taking a salbutamol reliever and actually focusing more on state preventers rather than relieving. As far as JR Calc cautions are concerned, we've got patients who are hypertensive, as we could cause that to worsen. We have angina patients, as that could bring on angina attacks, overactive thyroid. Late stage pregnancies, this can relax the uterus, and that's really not a good day to be having. And beta blockers, as this can cause severe hypertension. It's worth noting in the indications, one of the specific ones is a wheeze associated with beta blocker overdose. It's when a patient has taken over and above the beta blockers that they are prescribed, which is going to cause them hypotension. In the caution, this is about where patients who take a steady dose of beta blockers, whether that be to control anxiety, high heart rate, or blood pressure, as we're taking this away, it can cause their blood pressure to go up really high. So in summary, salbutamol works by turning on mechanisms to relax smooth muscles in the airway. The level of treatment for asthma patients should be directed by severity of outcomes. COPD exacerbations should always be referred for follow-up. We should be cautious about over-oxygenating COPD patients, but again, we should ensure appropriate delivery of the medication. Inline nebulization should no longer be practiced, and salbutamol may not be effective for children under the age of 2. So thank you for watching. If you have any questions, or that you feel I've missed anything, or if you have any experiences from your own practice that you'd like to share, please put them in the chat or put a comment below. Thank you.